Today we're going to get started. All right, we're going to start off with slash environmental exposure. It says volume 2. There usually is a volume 1, but that's mainly an environmental exposure talk. So we're going to talk a little bit about today, but most of it's going to be a toxicology review. So let's get started. Today is going to be a mammalian bites. Hold on, let me get some stuff figured out. So we're going to talk about reptile bites, mammalian bites, some lightning strikes, insect bites, acetaminophen overdose, opiate overdose, and salicylate overdose. A lot of this is going to be mainly just geared towards the boards. So kind of things that you need to study, things that you need to be aware of when we're dealing with this stuff. So a lot of this stuff most people know pretty well, so that's good. We're just going to focus on, again, board review type stuff. So reptile bites. Now, the big thing to understand is that there's two families, crotalids and elapids. And the main thing that we're going to have to know for this is to know the general management. Do you give crofab? Do you not give crofab? Can they go home? What kind of labs do you order to kind of assess whether these need to be admitted or not? So the big thing is when we're talking about crotalid families, those are those pit vipers. The most important thing is going to be assessing whether these are severe bites or not so severe bites. Depending on whether they're severe or not is going to be whether you give the antivenom or not. And that's your crofab. So the severity of the symptoms, I mean, there's a snake bite severity score that we use at the University of Kentucky. That's known throughout the country, and a lot of people use it, but there are other scores out there that people do use. But basically, the main components are signs, whether they're focal or systemic, coagulation abnormalities, and those are going to be your big things. And depending on whether you have a severe or not, that determines whether you get the crofab. Patients with dry bites can be discharged after an observation period, usually 6 to 8 hours, sometimes 12. But patients with also less severe bites can be watched for a little bit. And if you don't turn into a lot of symptoms, then those patients can also end up being discharged. If you end up giving crofab, those patients are going to have to be admitted and monitored for a lot of things. Are they going to have to be redosed? Are they going to develop compartment syndrome? Are they going to develop severe coagulation abnormalities? Those patients end up getting usually a monitored bed because you want to assess for DIC and things like that as well. Now, your lapids are a little bit different. These are going to be your coral snakes and things like that. Just one thing to remember, red on yellow, kill a fellow. The thing with these are that you may not have symptoms when they come in, but you may start having symptoms. Your initial symptoms may be delayed approximately 12 hours. And for that, you have to be worried because a lot of these elapids bites cause and respiratory paralysis. So the last thing you want to do is discharge these patients home and have them go into respiratory failure in their sleep without really even knowing it. And then they come in the morning. I know it sounds kind of bad, but you want to make sure that patients usually have to be admitted just for observation. Moving on, most of these questions are about management type questions. So kind of what we talked about for your crotalids, discharge if it's severe, if it's a minor bite or dry bite, and give crofab and admit if it's a severe bite. Elapids, admit. And then the big thing to worry about in general is antivenom in general is usually equine in nature, so you always run the risk of these allergic reactions. Bites. Now, mammalian bites are pretty easy to know. You have to make sure that you give antibiotics. You have to pathogens for these three: human bites, dog bites, cat bites. And then the other question is going to be, or do you leave it open? Now, human bites, that big bacteria that you have to worry about is going to be Eikenella. Strep and staph are also present, but most of these bites are polymicrobial. There's teeth fragments in there. You got to give prophylactic antibiotics. Now, these patients usually get sutured if it's on the head, face, or neck, and then you do secondary closure for anywhere else. Bites are also similar. Make sure that you inspect, irrigate. There's a lot of these bites. Sure that you leave it open if it's on the hands or and on the face. Obviously you can close. We close these all the time when you have those really large dog pit bull bites. And again, antibiotics for these patients. Now, if these bites are older than 12 hours, we had one a few days ago that was about 3 days old. He came in to get it closed. You tend to let it heal by secondary intention unless there's gross deformities that still can be approximated pretty well. And again, rabies, Tdap, as necessary for all of these patients. Just as a quick side note, most of these bites are also polymicrobial. Cat bites. Cat bites are your most common pathogen. Whenever they ask you what's the most common pathogen, it's going to be Pasteurella multocida. You want to make sure that you cover with antibiotics, rabies vaccines as needed. You also want to give antibiotics for these. Now, again, hand bites stay open, face bites get closed. You want to give prophylactic antibiotics for these patients, even if they have like prosthetic valves and stuff like that. Now, one caveat to the cat bite is not necessarily a caveat. Sorry, it's more of a thing to be aware of. Is it's not always going to be Pasteurella. There's one other thing that you need to worry about, and that's Bartonella Hensley disease. So, neuropathy bacteria is going to be Bartonella Hensley. Treat these. Usually, it's going to be coverage with like atypical type stuff. Be aware that most of these are going to be on their own. Usually, in about a couple weeks, they'll get better. So you can oftentimes, as long as it's not getting worse, as long as the patient is not very ill, you can let it be treated without antibiotics. All right. So again, these are the things that we need to remember as far as bacteria goes: Eikenella, Pasteurella, Bartonella, and then these need to be closed or not. Strikes. This is actually pretty important just in general, electrical injuries as well as lightning strikes specifically are very important. Know your resistances of your tissue. Nerves, blood, mucosal membranes, and muscle have than bone, tendon, and fat. So the thing to remember is the less resistance that you have, the greater the conduction is going to be. So that makes a lot of sense because with bone, tendon, and fat, you have less damage to those areas. Whereas oftentimes when you have a electrical injury, you can damage to your muscles, the rhabdo, and then also to your mucosal membranes as well. Life-threatening complications for electrical injuries, as well as your lightning strikes, are going to be respiratory arrest, cardiac arrest, and massive rhabdomyolysis. When you're thinking of just pure electrical injuries as opposed to lightning strikes specifically, is your AC is worse than your DC. One reason is that your AC actually leads to a prolonged contraction, so your exposure to the electricity is longer. The other thing to remember is that what is considered high voltage. So high voltage is going to be anything greater than 1,000 volts. Injuries get admitted. Low voltages can go home without observation. So oftentimes these questions will ask you, it's electrocuted, has no EKG changes, blah, 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 but what is your disposition for this patient? And they'll ask you, all right, well, send them home, watch them for 6 hours, then send them home, monitor bed, admit them to the ICU. When I first started out, I was like, well, watch them for 6 hours and then send them home. That makes perfect sense. But you can actually discharge these patients without observation. Make sure that you monitor your CK, your troponins, your EKG, full head-to-toe examination, especially if you have a exit wound and entrance wound that kind of crosses through the chest in order for it to happen. Then you obviously worry about cardiac abnormalities and this patient developing cardiac abnormalities in the future. So make sure that you understand that your injuries are not going to look as bad superficially, but may be significantly worse if they were to be debrided. They may have a lot of underlying issue. That's kind of the thing with electrical burns. There's a couple specific electrical burns that we want to talk about. Lit burns, kind of if you have like the kid that bites down on an electrical cord and has those burns on the commissures of their lips, are worrisome because you can have delayed labial artery bleeds. Necessarily mean that these patients need to be admitted, but it is something that you want to warn the parents about. It is something that you want to tell the parents to apply pressure and Vaseline to, but you do not want to peel back the scab or the burn, because that'll lead to bleeding. A couple in a day or so, if they're going to happen. Just make sure that they have strict follow-up precautions and a follow-up with plastic kind of manages to your electrical burns. The other one is lightning strikes, and that's kind of what we alluded to earlier. The big thing about this is going to be you resuscitate the dead. Even this has when you just talk about mass casualties, you resuscitate these people because there's still a possibility that they can have full recovery. The typical scenario in these patients are going to be a patient that's unconscious in the middle of a field with clothes that are partially burned, present with either like a cardiopulmonary arrest, a fern-like pattern on their skin. You may have immediate or delayed cataract formation, fractures and burns and dislocations, depending on how hard they. Management for these patients are going to be resuscitation, even if they're dead, or even if they're like in cardiopulmonary arrest. You typically manage all burns, and all of these patients get admitted to the ICU. You got to monitor them very, very, very closely. And these are kind of, again, the main pearls to take away from these electrical burns is burn AC is worse than DC. High voltage is considered greater than 1,000. Arrest, spelled that wrong, sorry. All right. And then your lightning strikes resuscitate the dead. Insect bites. We're just going to talk about 3 of these because these are the only 3 that matter. It's going to be your brown recluse and your scorpion bite. So brown recluse bites, remember that these are those brown spiders with a little fiddle on their back, usually not noticed by the victim. So bites to worry about. When your black widow, the person's going to actually feel it, and the brown recluse, the patient's going to notice the wound later on. These wounds are going to have local signs of tissue necrosis, as well as maybe some surrounding cellulitis. They're usually due to allergy to the actual bite itself. Now, how you take care of these are going to be management wound and kind of prevent local spread. They're going to ask you, do you want to give these patients antibiotics prophylactically? No, you do not give these patients prophylactic antibiotics, only if there's cellulitis present. And if there is local wound necrosis, then you get wound management and you see if there's any necessary debridement that needs to be done. All right, that's pretty much all you need to know about brown recluses. Widows, and these are going to be your the spiders with that red hourglass. Everybody knows what a black widow looks like. These are going to have local bites that may cause like a dull cramping sensation and localized diaphoresis. The patient is going to be the patient that's out in the woodshed, gets a small little prickly bite, doesn't really think much of it, and then they go home and then they get these severe abdominal pain and chest pain. How you treat that is going to be benzos. Give them narcotics, benzos, pain control, and then treat the local wound care. And then ultimately, these patients can be discharged home. There's rarely any abnormalities that happen long term down the road. Mortality is very low. I also want to kind of keep in mind is that you want to. Oh, sorry, I already mentioned that you want to make sure that you give them adequate pain control when they do go home. Oh, the other concept for both of these is there is an equine antivenom available somewhere in the world. You never need to give those. That's never going to be an answer for your test. Now, scorpion bites, these are graded. These actually have grades to them. So grade 1, 2, 3, and 4. Paresthesias is going to be your grade 1. Pain and paresthesias distal from the site is going to be grade 2. It's going to be grade 3. And then grade 4 is going to be cranial nerve with somatic, skeletal, and neuromuscular dysfunction as well. All these patients get local wound care, tetanus, and toxoids. And then you get symptomatic treatment as well. You can always give the antivenom for these as well, but all right, and here are pearls, just kind of briefly if you want to look at it. Radiation injury. This is going to be your big, honestly, pretty low yield. I don't think I had a question on my exam about it, but it did come up quite a bit on my practice tests. Is your main best predictor of survival is going to be your absolute lymphocyte count. So anything greater than 1,200 is going to be a good predictor. 300 is going to be a poor predictor. Hematopoietic cells are most sensitive than your CNS cells as well. Oh yeah, big thing is going to be your absolute lymphocyte count is going to be at 48 hours. Now let's dive into your Tylenol toxicity. We're kind of rounding it out here. So just a few more slides. So Tylenol toxicity, 2, 3, and 4. Phase 1 is going to be your anorexia, nausea, and vomiting, followed by elevated hepatic enzymes and coagulation studies. And then you move into phase 3, where you're going to have your altered mental status, hepatic encephalopathy, multi-organ dysfunction. And this is going to be when the patients come in extremis. After that, death or complete resolution of symptoms. So these patients, for the boards, we don't usually do these in real life, but within an hour, you can give your charcoal. It's going to be your answer. Toxicity with suggestion is greater than 200 milligrams per kilogram. sure that you get your levels, and this is kind of moving on to this Rumac-Matthew nomogram. You measure at 4 hours. Anything before 4 hours does not give you any information. 8 hours is, so if you have something above about, let's see right here, it'll be about 150 or 200 at 4 hours, you got to give him NAC. At 8 hours, that's when the benefit of giving the NAC kind of wears down a little bit. So you still get it after 8 hours for sure, but you want to make sure that you give it as early as possible as you can. They are going to ask you some secondary questions. They're going to give you these symptoms and then tell you that is your mind is obviously going to tell you Tylenol toxicity, but just remember that they may ask you, how is Tylenol metabolized? And one of those, the answer is going to be glutathione sulfonation. That's going to give you your non-toxic metabolite. But when you overdose, those things kind of get worn down. So you don't have any glutathione left. And that your toxic intermediate, which is your NAPG. And when your NAPG builds up, that's when you get your toxicity from that. And there's these two lines. So if your level is at 4 hours is like 50, that bottom line. If your level is like 140 at 4 hours, then technically, oftentimes people will treat anyways, but technically you don't have to treat because that line is taking into account the error. All right. So your pearls, Tylenol level at 4 hours or afterwards. NAC is your treatment, and your Rumac-Matthew nomogram is going to be the whether you need to give your N-acetylcysteine or this patient can go home. Patients are going to have to be end up seeing psychiatry, but from a medical clearance standpoint, if their levels are below the line, they clear. Opiate overdose. We're at in Kentucky, so we see this almost daily. Everybody knows how to find it. The cause of our altered mental status. Narcan is the treatment. Kind of determining whether opiate withdrawal, I feel like is really the most high yield part of this test because everybody knows the typical findings of opiate overdose. Abdominal pain, diarrhea, sweating, but your thing that will probably give it away is going to be your yawning. Because remember, diarrhea, sweating, inflammation, piloerection, those are also symptoms of that are found in cholinergic toxicity as well. So you're yawning, there's going to have to be something that gives the symptoms away, and it's going to be yawning in this case. Overdose, and I believe this is the last thing we're going to talk about today, and then we'll kind of let you guys go on your way. Toxicity, big couple questions they're going to ask you. This is going to be high yield. I almost guarantee that you'll have 3 to 4 questions on salicylate toxicity on your exam. But respiratory alkalosis is the primary one that you get. Then it's followed by this. Respiratory alkalosis, if your respiratory center. There are a couple things that you want to think about when you think salicylate toxicity. It's not always going to be, hey, this person took aspirin. Sometimes it's going to be oil of wintergreen. And for the longest time, I didn't know that was a salicylate. Sometimes some of those creams have Bengay or something like that has one of those creams. I may be mistaken. I would check myself on that. Some symptoms that you may have: ototoxicity, tachypnea, nausea, vomiting, abdominal pain, tinnitus. It starts off with kind of CNS symptoms and can progress to cardiac dysrhythmias, pulmonary edema, renal failure, and hemorrhage. Management is done with salicylate level at presentation, measure electrolytes, measure BUN, creatinine. GID contamination is going to be key within an hour. Filtration of your aspirin via alkalinization of the urine with sodium bicarb is also an option. And then finally, these patients, if they are altered, if their levels are greater than 90 to 100, severe symptoms, severe acid-base abnormalities, these patients will ultimately end up needing to get dialysis. Not something to joke around with. It is something that needs to be found early, it needs to be treated early, and it needs to go to the ICU if it's a severe toxicity. And then always consider dialysis for these patients. The one thing to consider about these are, again, it's the differences between your salicylate and your doses. It's going to be, these are going to be your two main toxic exposures that are absolutely going to be on your boards. So just remember that for your Tylenol, your levels at 4 hours, salicylate, measure immediately. And alkalinization is your typical treatment for your salicylate toxicity, and your Tylenol toxicity is going to have your and then kind of symptomatic management after that. All right, let me quickly make sure I don't forget anything. And that's it. There's a couple other things I'm going to put up as a blog for the rest of the toxicology block. I have about 5 different slide sets for that. So it's kind of toxicology and environmental exposures brought together. That's pretty much it. So